Thank you, Eric, and thank you all for having me and letting me share a little bit of our work here at Yale on studying this epidemic. And I wanted to start by saying that uh, before this, I've never studied a respiratory virus. That as a lot of people have, moving into this realm to help with what is an ongoing public health crisis. My group primarily studies mosquito-borne viruses, so dengue, Zika, West Nile virus, and we have a lot of experience with investigating outbreaks. And in December, when the news was trickling out that there was these mysterious cases of pneumonia from China, and then into January, as it was determined that this was a coronavirus, and things started to build. Even at that point, we weren't really considering getting involved because we didn't know what we really had to offer. And then as it became pretty clear that things were going to spill over into the United States, as a group, we made a decision that we're going to try to figure out how we can be helpful. We have a molecular biology lab, and so we created reagents for testing and sequencing protocols, things like that, to have them on board. But still, I think we're all a bit naive about what was actually gonna happen. And so if you think back to early March, which I know like 3.5 months ago seems like many lifetimes ago, we're at this point when in Connecticut, shown in the orange, we hadn't had any cases yet. And even in New York, there was just a few. It was primarily in Washington that we started to see local outbreaks start to take off. I think it was right around this point for us that it became pretty clear what was going to happen on a local level. I think maybe we were a bit in a denial for a while, but around this time, the oh crap moment, I think was those alarm bells were going off, and a lot of places were just completely unprepared. And so we formed a group with the Yale School of Public Health and the Yale School of Medicine, and you can see pictured here. And we came together to discuss really how we can help our hospital and support with testing, because they at this point still did not have a diagnostic assay in their hands that they could actually use. And we also really just wanted to help in general with diagnosis and surveillance, and then understanding immunology and pathology and epidemiology. There's a lot of really important questions. And in this picture, I don't know how well you can see it, but in the background there is actually the Johns Hopkins dashboard. And there were 45,000 cases worldwide on that day on March 2nd. But what came out of that meeting is that we were going to create a clinical research study with our hospital that we called IMPACT, which is Implementing Medical and Public Health Action Against Coronavirus in Connecticut. So obviously we came up with the acronym before we actually had the words for it. But on March 14th, so 12 days after we conceived the idea, that it went live, and we are collecting our first samples from the hospital. In this IMPACT study, we enrolled 2 separate cohorts. We enrolled inpatients, so we were collecting various samples from them, through the time course of when they're admitted, to the end of the course. And these range from severe patients to mild disease. And we also enrolled a healthcare worker cohort so that we could study asymptomatic infections and asymptomatic transmission. And this study has fruited a lot of, I think, really important work. One, that we found that saliva is a great source for testing as compared to the standard NP swabs. We discovered a lot in terms of pathology, that placentas can get infected, immunology showing, why men have, worse clinical outcomes and higher viral loads. And then a lot on the epidemiology side, diagnostics and surveillance. So I'm just going to talk to you about one sliver of work with that, and that is what we have been doing with genomics. So on the first day of testing for our research group, so first I'll say that, I'm not a clinical research lab. Again, we studied mosquitoes. We have done some work with clinical samples. And so we had to like change the way that we operate to become this, what I'm calling a research grade clinical testing facility. So we're not a CLIA approved lab. Everything is just for research. In these 3.5 months, our small operation has tested about, I think, 8,000 to 9,000 samples, which, in the grand scheme of things is pretty small, but for our small operations, we're quite proud of that fact. And then, on the first day of testing, we have a positive. And now this gets into our wheelhouse of things that we're good at. We're good at sequencing viruses. And as started by our star postdoc, Joseph Faber, and then picked up by a new postdoc, Tara Elpert, we've worked out this rapid sequencing technique. And so maybe some of you are familiar with MinION. If you're not, it's a handheld sequencer about the size of your phone that you can plug directly into your computer. And what's great about this is you don't have to rely on large genomic centers. So you have control over this. So we were able to generate our first genome about 12 hours, 13 hours after we first identified it. And then Joseph also set up our computer with this program called Rampart, which as we're sequencing the virus, we're able to live map it to the virus genome. So you can see that here's the coverage of reads across the genome. This is really early in the sequencing run, so we don't have the full genome here. But once that becomes full, then we just stop the run. And how we did the sequencing then goes back to our work with mosquito-borne viruses and our studying of the Zika epidemic. So early on during that epidemic, we realized that we needed a new rapid sequencing technique. And so working with some folks, Nick Lohman and Josh Quick in Birmingham, we came up with this protocol called Primal-seq, where we essentially took the whole genome and we chopped it up into these 400 base pair amplicons. And so for something like Zika virus, we could amplify the whole thing in 35 amplicons. For coronavirus being 3 times larger, this is 98 amplicons. And you just put the non-overlapping pieces in 2 separate PCR reactions, and then you pool those together for sequencing. And if anybody's familiar with sequencing, this is now called the Arctic protocol because Josh Quick put the protocol and the primers up on the Arctic network website, but we still call it Primal-seq. And so with this setup and this first genome sequenced, we went to the Connecticut Department of Public Health and asked for some earlier samples. So we started our study on March 14th, but we got 8 more going back to March 6th. And we wanted to get this early snapshot of the outbreak in Connecticut. So here on the right now, you see a phylogenetic tree, and this work is done by Anderson Brito and a collaborator, Anna Hodcroft. And the viruses from Connecticut are shown in this greenish blue color. You can see 2 of these are down in this lower part of the tree. You can also see during this, there's actually not that many sequences in this phylogenetic tree, because again, this is like early March. There's like 30,000 available now, and this analysis had like 180 or so. But it looked like one of these introductions into Connecticut came from Europe. Another one looked like it might have come from Asia. And we have a lot that all clustered together here. And if we zoom in on this cluster, we find that these viruses are most closely related to viruses that were sequenced from Washington State. So again, going back to Washington State is when we had the earlier outbreaks in the United States. And so that was really interesting. I wasn't expecting that. I was assuming, like a lot of other people at this time in March, that these were, all these outbreaks were independent, introductions and transmission from international places. But this here showed that, early during the outbreak, that the epidemic in the United States, in early March, we already had coast-to-coast spread of the virus. Now, because we didn't have a lot of data from the central part of the United States, we don't know if the virus came directly from Washington into Connecticut, or if it stopped along one or many other places along the way to get there. But again, we still had this happen, and it allowed us to formulate this hypothesis that during this period, that domestic spread was greater than international spread within the United States. And this is where the genomic data is a bit limited at this time, where we can't actually test this hypothesis. So we had to dive into some other data. And for this, our group likes to use travel data. And so now we're about a week after we've sequenced our first case. We're in mid-March, mid to late March, and we wanted to get this out really quickly. So we took a simplified approach to addressing this question so that we could have this done within a week or so. And actually, all the analysis that I'm going to show you that went into our publication, we did in about 24 hours. But we took the 5 largest international outbreaks and the 5 largest domestic outbreaks that were outside of our region. So we're counting New York within our region, so that's not being counted in this analysis because we want to look at airline travel, and there's not much airline travel between New York and Connecticut because people just drive or take the train. So when we look at these 3 large airports in our region, and for New York, we're referring to JFK, that you can see from these 5 domestic locations, there's just a lot more, daily passengers coming into these airports than there are international passengers. And so even for New York, which is quite an international airport, that was kind of surprising. So passengers coming in from places that have outbreaks is only one part of the equation. The other part is, well, what is the likelihood that any one of these passengers would actually be infected? So to start, we took the prevalence or the incidence rates over time of the virus from these different outbreaks. And we had to put in a normalization factor because we know that surveillance in each place is not the same. So we had to sort of arbitrarily increase or decrease cases based on what sort of surveillance system that they had. And then we also had to put in a sort of sliding window around the cases because we know this is just when they're diagnosed, but these individuals could be infected for some days before and some days after that. So when we combine the daily passengers and the likelihood that somebody can get infection into a model, we have an output that is the travel importation risk estimate coming into those 3 airports that I mentioned that are around Connecticut. And so the numbers on here are arbitrary because this is just a sort of, a relative risk. You can see in this purple line, this is the risk over time of domestic importations into the Connecticut area. And you can see by March that this really starts to take off. And this brown line is the international importation risk. So one major caveat of our work is that by the time we were trying to do this, that 2020 airline data was not available. We had to use 2019 airline data. And there's going to be a big difference between the 2 of those data sets because of the travel restrictions. So these flags that you see here are when different travel restrictions were enacted. And so like the travel restriction to China, as the, overall didn't really have that much of an impact here because you had very few cases in China actually at that point. And then also the one for Iran didn't really have much of an impact because there's not that many travelers between Iran and these airports. The only ones that really made a difference were then when the travel restrictions were enacted in Europe. And so we looked at this, like what happens if 40% of the travel was reduced, because these travel restrictions don't reduce all travel. And so at 40% and a 90%. And so you can see immediately there would be some sort of impact. But even if there was no travel restrictions in place, that we see that the domestic importation risk had already surpassed that of the international. So in likelihood, and I think to nobody's surprise, that these restrictions were put into place, retrospectively, these were done way too late. And, that domestic importation is actually something that should have been a much higher concern. And what's also interesting is that these importation risks mirror the curve of the outbreak in Connecticut, and it's just about a week and a half prior to that. So combined, if you would like to read more about this work, we published it recently in Cell. We had it on medRxiv for a long time. And again, to recap, the point of this is really during the epidemic in the United States, you had coast-to-coast spread and a lot of overall domestic spread that was happening. So I just spent about half of my time telling you about what happened in about 2 weeks during the outbreak. So, what about the rest of the outbreak? And we can't really go around trying to publish papers for every 9 genomes that we sequence. That would be no one would probably want to read those, and it's a lot of work to do. So we had to come up with another framework for us to keep doing real-time genomic epidemiology and get this information out into the public, where maybe it could have an impact or at least be of interest without having to go the publication route. So 3 students of ours, so 2 MPH students, Cheney and Cole, and an undergrad, Peter, built this fantastic website for us that you can find on covidtrackerct.com, written in the corner. And this was supposed to be our landing page for all of our data. There's a section on here called Why Genomics that explain what genomic epidemiology is and how it provides information. All of our protocols are there. There's even a translation for this into Spanish. But importantly, what we've added to these are these situation reports. And we used to make these reports weekly, and now we don't need to do them as often. But what they do is they walk through our data into some detail for people that study phylogenetics, but also in simplicity as well, so that anybody can understand it. And if you know NextStrain, or if you're familiar with that, we actually have a live window into our own NextStrain builds with, that just highlight our data built into the page, so you can directly interact with all of our data. There's links to go and download it. We talk about the public health significance and the policy, concerns, or how this might impact policy along the line. Okay, so, I've told you now that we have this website and we have all this new data. There's about 250 genomes now from Connecticut. So what is the story now, after, looking at just the first 9 genomes? And what we're seeing is a change in epidemiology from that very early, snapshot into the outbreak that we had in March. And so all of the genomes from Connecticut are then highlighted in this green again. And then essentially this is a, phylogeography, it's what it's called. So it's colored by the location of the inferred ancestors and how they're related. And then because we have a time component and a spatial component, you can then map this. And so all these different lines then, as you might think, would show then where introductions are coming from. So the outbreaks in Connecticut are driven by, many, several hundred, several thousands of separate introductions that led to local transmission. And a lot of these introductions are coming from New York. So that should make sense because there's a lot of travel between New York and Connecticut. Also, they're coming from Europe. And again, they're coming from this coast-to-coast Washington clade. And also, there's the evidence now from our data that these outbreaks were starting actually in mid-February. So a couple of weeks, maybe even further back, before that March 2nd date, where we're just sort of anticipating that an outbreak was going to come. Then at that point, we actually already had local outbreaks, but we just didn't have any testing capacity to actually detect these things. And so what you also might notice here is that, compared to that first snapshot that I showed, that most of it looked like it was coming from Washington, we have a change. And so if we look at these lineages coming in from New York and Europe versus Washington, or, again, maybe not directly from Washington, but that came in through that side of the country and then spread across, that, again, if you look at early on, there is a dominance or a large number of these introductions from Washington. And then through the course of the outbreak, this gets displaced by these other viruses. And there could be an easy epidemiological answer for this, that more people travel back and forth between New York and Connecticut than they do from the rest of the country into Connecticut. But what's also interesting that Carrie brought up as well is that these two lineages are defined by this mutation in the spike protein, the D614G change. And and I completely agree with Carrie's take on this. I'll just say that there is some in vitro data showing that this G allele actually infects human cells better than the D allele. And some places show that, you know, people that are infected with the G allele actually have higher viral loads than those that are infected with D. But importantly, no one's really finding a difference in clinical outcome based on what one you're infected with. So it's really unclear, you know, how this mutation actually impacts transmission or how it impacts clinical severity. You're going to see a lot of this work coming out soon. There's several preprints on it. You know, anytime you talk about a mutation, there's a lot of news around this. So we do see that this G allele is becoming dominant in Connecticut. And while it could be because there's actually some, you know, competition that these viruses are more fit or better transmissible, it's more likely that it's just the epidemiology is that you have more chances for introductions coming from New York. This will be a really interesting field to watch. So if you looked at the program, I think it said, you know, genomic epidemiology of SARS-CoV-2 in New England, and I haven't really talked about New England yet. I mainly just talked about Connecticut. So I'll give you a brief overview of what's happening. I think, you know, in New York, I'm sure most of you are aware of the stories of you know, the phylogenetic analysis that have happened and showing that the outbreak in New York was fueled by, you know, many different separate introductions coming in from Europe. And then from New York, it's, you know, is a hub for travel around the country, and therefore as a hub for spread around the country as well. And that, you know, just saying what I said before is that then there's a lot of spillover then from New York into Connecticut. So these outbreaks are just, you know, highly linked together. What's interesting is that in Massachusetts, shown in red, and you can see the genomes along the tree here, while there is some that are dispersed throughout, showing that there probably is some back and forth transmission between these areas, there's also some that seem to be disconnected from the rest. So, you know, there could be some other local outbreaks that have happened in Massachusetts that are independent of what is happening in New York and the other places. But also, if you look at this map, you'll see that there's a large blank area where we don't have any data. And so what our next steps are is that we're currently partnering with the VA hospital system. So in New Haven, our VA hospital serves as the reference diagnostic laboratory, and it collects clinical samples from VA hospitals from all through this region to do testing. We're really close to having our IRB completed, that we could actually sequence these and actually fill in this entire New England region. And, you know, that's going to be really interesting because, you know, as opposed to Connecticut that's so closely connected to a very large city.
2-minute warning, Nathan.
Perfect. My last slide. That, you know, Vermont and New Hampshire and Maine, you know, aren't going to be as connected by people that are driving between, or maybe not even as many flights going back and forth. So, you know, we're really curious to see how it is that the outbreaks in these states receded, where the virus is coming from. And that'll help us understand of what's going to happen for these, you know, subsequent waves of outbreaks. So in Connecticut, it's, you know, for us, we watch what is happening in New York City, and we're about a week behind that. You know, it's unclear, you know, how these outbreaks are connected to actually have some sort of another place that you can monitor to determine what might end up happening here. So there's a lot of different people that contributed to this work, both at Yale and around the world. I'm not going to mention, you know, all of these people, and obviously I don't even have their names up here. But I really just wanted to highlight the very hard work that was done by my group. I know a lot of groups, when the outbreak happened, couldn't come into the lab anymore. Mine was the opposite, as we worked, you know, double, triple the hours, and my lab grew about, you know, twice in size. And so a lot of hard work and dedication, not just for this project, but all of our clinical projects. And if there's time, I'll take some questions.
Thank you, Nathan. That was a wonderful talk.
Nathan, I'm going to ask a question. It's Rodney
Okay.
Rothstein. Darcy asked the question of Carrie last time, and I'll ask you. Do you see any evidence for genetic recombination between viruses?
Yeah, I was hoping that I was going to get asked that question. So I think I will start to say that this analysis for SARS-CoV-2 right now is difficult. And that's because these viruses are so closely related that you may have recombination that's happening, but when you have recombination of very closely related viruses, it's hard for our methods to actually detect those. Um, and also, when you're pulling this huge data set of now 30,000 genomes from around the world, you don't always know how other people are doing their sequencing and doing their quality control. So something like lab contamination can actually look like recombination. So the short answer right now is no, we don't see any bona fide evidence for recombination. Could it be happening? It could. If these viruses obviously recombine, throughout their history, but this really happens over the course of, hundreds of years, tens of years. But, we don't really know the rate of recombination that is happening over the time course of months.
Can I ask a question? It's Darcy.
Yep.
So we're always grappling with having the science that we follow inform the policy of the academic institutions at which we work. And I just wondered if and how that was going at Yale. It's been a very, how can I say, complicated conversation at Columbia.
I'm going to give you the politically correct answer, and then maybe we can talk offline about the other answers that go into that. I think you're right that it's complex. You have a lot of people having to make decisions based on limited information, and it doesn't make everybody happy. And while people just say, "Why don't we do more testing? Do more testing? Do more testing?" It's more complicated than that. Of like who can actually do the testing and everything. People want us in our research lab to do testing, but obviously we can't do that for a whole school because we're not a CLIA lab. So I think now that we're all given into a period of a little bit of break from the chaos of the full-blown outbreaks, that people are able to think a little bit more, and I am starting to see some better policies in place, and they are pulling in, the public health experts and the scientists to be leading these committees. So, sorry, that was a lot of words to say. It's going better, but it could be better.
Yeah, I really do think it could be better. There is a group at Columbia working very hard on a home test, and getting that put into place is, of course, got a lot of hurdles to step over. But ultimately, for all of these things, that kind of thing is the thing that we're going to need. So if you guys are interested in that, just drop me a line, dbk3, columbia.edu.
Got it. Thank you.
I think Eric's internet has cut off, but Margaret, do you want to ask your question?
Hi, thank you so much for an interesting talk. I was just wondering, can you talk a little bit about any sort of disparities that you all might be seeing in New England?
Disparities in terms of
impact on people of color.
Oh, yes. Okay. So absolutely. I think, everywhere you're seeing that, you have a higher infection rate in African-American populations. Definitely this is unfortunately, I mean, this goes back to even when I studied Zika virus, that, the, economic disadvantage are the ones that are impacted the most by any infectious disease, and COVID-19 is no different. So yes, we see it. We are trying to prioritize testing into those communities and provide them with access to free testing. And I wish a lot of these things were implemented a lot earlier.